you do your voting on this, please, and Simone will organise what's happening with the voting and report back to us what everybody thinks. So how are we going with that, Simone?
Yes, have we got some answers coming in? Yes, we have. So that's great. It looks like most of us have voted. So we'll share those results. They should be coming up on your screen now.
Yes, they've come up. So 34% of people think that the receptionist should say she's in the waiting room, and 66% say that they shouldn't. I'd like to suggest that maybe this is the beginning of confidentiality in our waiting room, and as part of our practice confidentiality. And maybe we'll ask Sally how she's, what she's feeling about this and what she would want to have happened.
I was pretty nervous actually coming in today. I didn't tell my partner that I was in here. I didn't really want him to know. And I mean, if he knew I was in here, when I got home, he'd be asking me a million questions. So I wouldn't want him to know that I was in here.
And so you feel it would present difficulties for you, and so that for you it's important that the receptionist doesn't give away that sort of information.
Oh, yeah, I definitely don't want him to know I'm here, so I definitely don't want the receptionist to say anything.
Yeah. So I think this is an important issue. It may not be important to some of our patients, but it's particularly important where there are difficulties going on in families, and where the perpetrator may be stalking the victim, where there's issues that people do not want other people to know that they're at the doctor or what's going on. So that's an important question to talk about within your AMS or practice, and work out a policy that that you think is the best for managing that, remembering what Sally's saying. All right, so Sally does then go in to see the GP, and she's looking a bit distressed today, and you're wondering as the GP what might be preventing her from getting better. And so this is a moment at which we could ask ourselves, could this be family violence? And in this webinar, we're going to look at two possibly different responses from Sally as you talk with her today. So, hello Sally, nice to see you today, but you are looking rather distressed.
Oh, I'm fine. I'm okay. No, I'm fine.
You're fine? Is anything happening at home? Any difficulties and things at home?
No, no. There's nothing wrong at home. Everything's fine.
Everything's fine? And you're never feeling frightened or having any difficulties like that with your partner?
Oh, no. He's okay. Everything's okay.
So Sally, if there was a time when there were any problems like that for you and for your children, then please feel that you could talk to me about that.
Yeah, thanks for that.
So how's Sally feeling with the doctor sort of talking to her and asking her those sort of questions?
In that instance, not quite ready to talk about it yet. I haven't told anyone about what's happening, and, you know, yeah, a little bit nervous and a little bit unsure, so I just didn't want to say anything.
So not ready to talk?
No.
What's it like to be asked, though, when you're not ready to talk?
I appreciated being asked because it made me think that if I did want to tell, I could tell, you know, you. But, I mean, I don't want to feel like I'm hassled about it. Like, I'll tell you when I'm ready.
So we need to respect what you're saying, even though we may think that something is going on.
Yeah.
All right. So we're going to do it again in a slightly different way. So, hello, Sally. You're looking rather distressed today. How are you?
I'm okay.
How are things at home at the moment?
They're okay. Maybe a little bit rough at the moment.
So, do you ever have times when you feel, you know, frightened or afraid of your partner?
Sometimes he gets, sometimes he can get quite angry. Not all the time, just sometimes he does get, yeah.
So there are times at home when things are really not very good and his behaviour is making you fearful?
Yeah, sometimes, yeah.
So this may be contributing to some of the reasons you've been depressed and in the last few months. Do you see any?
Yeah, it certainly hasn't helped. I mean, certainly he's seems to be getting angry more often lately. Yeah.
So we've talked before a bit about confidentiality, and I really appreciate you starting, you know, being able to tell me a bit about what's going on at home. And we've talked about how what we talk about here is in confidence, but there might, you know, become a point at which I really, you know, I'm really concerned about your safety and the children's safety, and, you know, we might need to do something about that at the time. So that the it is in confidence, but there could be limits to that if I was really worried about your safety. So can we talk a bit about your safety, seeing you're just sort of identifying that things can be very, you know, quite difficult and fraught at home sometimes. So do you think you are safe to go home today?
Yeah, I mean, today's fine. I mean, it's usually at night that it happens, and usually on a Friday or a Saturday night after he's been down at the pub.
So it's related to when he's drinking, or is he
how much is lost when he's, yeah. Betting on the horses, really.
Okay, so it's his drinking. It's about his drinking and his gambling. That's what appears to be one of the precipitating factors.
Yeah. If he's one,
have you talked? Sorry, I missed that.
So if he's one, he's in a great mood. But,
I see. Sorry. Yes. And have you told anybody about this?
No. No. No, I haven't. You're the first person I've told about it.
And is there anybody that you feel, other than me, that you could talk to about it? Any family or friends?
I could probably tell my sister. I think she knows anyway, to be honest. She's asked me a few questions about it, so. Yeah,
so you think you could maybe talk to her about it? How far away does she live?
She's just down the road. She's almost in walking distance. It's yeah, only a couple of streets away.
So if you talk to her about it, might you be able to go there if you needed a safe place?
Yeah, yeah, she'd be all right with
Could you talk to her about that?
Yeah, I could. Yeah.
So you're saying that it happens more often at weekends, like on Friday or Saturday night?
Yeah. I mean, he doesn't drink much during the week. He's got work the next day. But...
And does he check up on you and do things like that?
Yeah. If I don't answer my phone or I don't respond to a text message quick enough, he gets angry and, yeah, wants to know where I've been and what I'm doing. And
so he's really keeping an eye on you. And has he ever threatened you with a weapon, with a knife or a bar or a gun or?
No, it's just his hand, just
no.
his fist.
Is there a weapon in the house?
No, nothing like that.
Right.
I don't like them.
And have you ever needed to go to hospital because of injuries and things that have happened to you?
No, it's never been like that. Like a few bruises and stuff.
Okay. So you feel safe enough to go home today?
Today should be fine. I mean, it's a weekday.
All right. Okay. And what about the children?
They're normally with their grandparents or their cousins on the weekend, and I think that's also why he does it, because the kids aren't around on a Friday, Saturday night very often.
Yeah. So we need to think about their safety too, and we think sometimes that we hide things from our children, but they do, they are aware when there's tensions and fighting and difficulties going on. So, okay, so we've just talked a little bit with Sally about what's actually happening for her. She's moving from being sort of pre-contemplative about what's going on to actually contemplating that what's happening to her is a form of family violence. And we've talked about her safety and things. Sally, how we've talked about these things. How is it for you? Tell us about what it's like for you talking about these things.
Kind of confusing. I'm a little bit nervous. I don't really know what to expect. I didn't actually come in here meaning to tell you about it, so A little bit nervous, a little bit scared about what's going to happen. Yeah.
So, all right. So, often when we become aware that some family violence is occurring, we've got a waiting room full of people, and we need to sort of think about how we're going to sort of manage this situation. And but Sally says that she's, on this occasion, that she's safe to go home. Would there be other people in your AMS or practice who might be able to help or support Sally? So in some of the practices that I've been to talk to, then one of their Aboriginal health workers or the practice nurse has an interest in this and is sort of willing to offer support. And also it's really important to find out what's available around in your particular area. So we're talking to people sort of all over Australia at the moment, and later on when you get a chance to look at the White Book and some of the information and contacts in that, there may be some things there that would be helpful to you, but it's also exploring what's available in your particular community and getting those contacts into your computer so that they're there when you may need them. And in some parts of Australia, it's going to be really very limited, the number of services and things that are available just in your area. But you may have heard about the 1-800 Respect line, which provides support and counselling to women in domestic violence situations and sexual assault. And you could even think, if you need some specific help, that you might put Sally in, if she was wanting some more help at that time or at a latter time when you see her, of putting her in a room and allowing her to use that line to access support and counselling. And then it comes for us to think about what follow-up are we going to arrange with Sally. And we're going to do another little polling and think about what follow-up arrangements, when are we going to arrange to see Sally again. And the polling will give you some options if you'd like to decide which of those options you think might work for you and Sally. And Simone's going to get those organised so that we can see what follow-up. People who are involved in family violence are a bit like somebody with a chronic disease. It's not something that's going to be solved today, and we need to work out ways of managing that, working with the patient at the pace that they want to work at, and seeking solutions that they think would be helpful. So what's the polling? Right. Okay.
So that should be showing up on your screen now, the results.
Thanks very much, Simone. Okay, so we gave the options of tomorrow, and if things were very worrying and fraught, you may well want to get her back tomorrow or in a couple of days, next week, or that we would discuss a time with Sally. So Sally, what's your feeling about how you'd like to be followed up?
I mean, I've got the kids, so I don't know, I would have to find a time, and I don't really want my partner to know I'm coming in too often, so I'd like to talk to you about finding a time that works for both of us. Yeah.
So it's really important when we're working with somebody who's been involved in a situation where they have little control, that we work to empower them. One of the important things that we can do in this situation is to empower Sally, and so to work with her about a system that's going to work for her and for us, but making sure that we really do want to follow her up carefully. Now, who else could we involve? So we talked a little bit about this before, about whether we might involve, if we've got practice nurses who are seeing people. Practice nurses are sometimes picking this up when they're immunising children, when they're following up on antenatal care. We may have Aboriginal health practitioners who've got a good understanding of what's happening with this patient within the community. We may have links to a psychologist who has an interest in family violence. We may have a domestic violence service. And the police in all states now have had a lot more training in domestic violence, and in fact they're a group who are seeing a great deal of domestic violence, may be able to help you, may be an appropriate person at some stage to help your patient. So when I was talking in Tamworth around this issue, we had one of the domestic violence liaison police officers there, and we were talking to her about how much domestic violence the police were seeing, and they were seeing 500 cases a month. And when we're in Dubbo, when we're in Wagga, when we're in Western Sydney, all the domestic violence police officers who came to talk with the GPs were saying very much the same sort of thing. So the police are certainly, and then at some stage you may need some legal service advice from one of the Aboriginal legal services, family legal services. So how's Sally feeling at the moment? Now we've started to talk about some of this stuff.
It's a little bit uncertain. I really don't know what to expect. I don't know what he would do if he found out. I told you. Little bit scared, really.
So one of the things that's frightening you is that your partner will find out that you've talked about this.
Yeah. He'll need to find out.
And if he did find out that you talked about this, then there's likely to be, you're likely to be getting into difficulties and trouble with him. He's likely to be violent. He's likely to take it out on you.
Oh yeah, yeah, I'd know about it.
Mm-hmm. So in order to keep our patients safe, this confidentiality around this issue is really important. So, Brad, in your practice and things, who have you found to be helpful? Who have you been able to call upon in this situation?
Well, I think the general practice team is really important here. And so, you know, whether it's an Aboriginal health worker, the practice nurse, reception and admin, all play a really crucial role here, because it's whoever is going to interplay with Sally or someone like Sally as they come through the practice. And I think the other thing, it's really good to actually help people to develop a relationship outside just the GP. So if you're not available for whatever reason, then they can feel that there's a safety in coming to the practice. I think that's really important. And I think from Sally's point of view, we need to also find ways to make it safe for her to come along to the practice. And, you know, it's particularly in small country towns, we talked about the other day, you know, people will see her coming and going and may well, you know, make comment or tell a partner or just make innocent comment. And I think that, you know, working with her to come up with, you know, a solution as to why she's coming. I mean, it might be worth, you know, having a bit of a check on her blood pressure as we move forward, so that she's got a reason to attend on a regular basis. And that also means that she's developing that relationship with the practice nurses and others within the practice.
So in terms of confidentiality, then we need to engage Sally in saying that she would be able to talk to us, or she would be able to talk to somebody else, whoever it was. But we'd need to sort of engage her in that process so that she feels the confidentiality is maintained if other people become involved.
I think that's the important part, is that Sally needs to know that confidentiality isn't just a relationship between her and her general practitioner, but actually within the general practice itself and further afield.
So we're wondering if this is just a small scenario we've done about one thing that Sally could have presented with. There are many, many ways that people present to practice where there's family violence involved. People come, you know, with sleep disturbance. People come with chest pain. People come with skin rashes. People come with all sorts of things. And I guess that's what makes it difficult at times for us to keep in the front of our mind that one of my Aboriginal patients had a lovely saying. I was asking her when we'd been talking about diabetes, how that had been for her, and she said that was wonderful. She said, now I understand the underneath story. And I think what we're often looking for here is the underneath story. So, Simone, have we got some questions?
Yeah, we've got some great questions coming in, Libby, and picking up on really where we ended the presentation, talking about Sally and confidentiality. I've got a few questions I might pose to you in a bunch that we can have a bit of a discussion on. So one of those is when Sally comes into the practice, if she doesn't actually indicate anything, I've got a question here. If Sally did not indicate anything, what should the receptionist tell the partner? And also, there was a comment later on that may be able to be linked to that. In small towns where everyone knows everyone, the question is, what is the receptionist talks about it out? So I'm sorry if I'm not reading this question properly. You may want to send that in again, Salman. But in small towns, everyone knows everyone. Question is, what receptionist tells their partner outside maybe in a supermarket, then she could be in trouble then. So just again, the difficulties that receptionists face as well with dealing with that. Do we want to comment on that, please?
Well, I think it's something that we certainly need to talk to. In my previous practice, I lived and worked in the same suburb. We had receptionists who lived in the same suburb, and we had a rule that nothing was, that if that no information was given about patients over the phone to anybody. And so the receptionist would say, I'm sorry that I'm not able to give you any information about patients. So that was the, you know, what our practice had sort of decided on and talked about, and that's, you know, what the receptionist said. Now, I'm sure not everybody does exactly the same thing. Brad, what's your feeling about that?
I think it's really an interesting question. I mean, not a day goes by that I don't indicate that I'd much rather be the GP than the receptionist in the practice. It's really hard to answer those calls and take those calls, but it's really important that at the end of the day, people realise that, you know, what happens, you know, within the practice stays within the practice, and that can be really hard. Living in a small country town previously myself, you know, there's throwaway comments made at social events, and, you know, people respond without even thinking, just naturally. And I just think that as a result of that, people need to realise really, you know, it's a focused approach to making sure that we don't find ourselves in a compromising position, but more so that we don't leave Sally in a compromised position as a result of that. And, you know, there's numerous examples of how that might occur. And I think, you know, it's probably an overkill to say that, you know, if someone was to ring up, the policy is, well, don't know about who's in the waiting room, but certainly Qantas and the like get by with that. They won't tell you who's on the plane. And I think that, you know, that sort of stuff's really important, and however we approach it, as long as we've actually discussed it with the staff and come up with what's going to work within your practice, I think that's really really an important way to move forward. Sally needs to feel safe.
And we've got quite a number of questions, so we'll move on to the next one. Again, I'll phrase two together. There was a question whether Sally's husband in the scenario is Aboriginal as well. And another question that perhaps stems off from that is, Libby, when talking to Indigenous patients, which is the way the question was phrased, how important is the language you were using? For example, the words sad, scared and worried. Did you specifically choose those words over depressed and fearful?
I think when I'm talking to patients, we all want to use words that the patient's going to understand and not technical words. We're all going to say it slightly differently. So, but we need to think about the sort of words we're going to use. So it's not necessary to use the exact words that I used, but they're the sort of words that I would use when talking to one, you know, to one of my patients. How do you feel about that, Sally?
The words you used weren't intimidating, but they weren't patronising either, and I think that's really important. You don't want to speak down to people. I mean, you're right about using technical language. I mean, health literacy should not be about the client understanding what you're saying, but you actually speaking in a way that the client's going to understand. So I think that was, what you said was perfect, because everyone's going to say it differently. It needs to be your own language, but yeah. Don't want to use too intimidating language. And in relation to the other part of the question, I don't think it actually matters whether my partner is Aboriginal or not. It's really when I'm in this session about me. Libby?
Yes, I don't think it matters at all whether your partner's Aboriginal or Torres Strait Islander or Irish or whatever. Yes.
Yeah, I'd like to touch on a couple of questions now that talk about involving others and what to do when Sally feels unsafe. So again, I'll phrase a few questions together if that's okay. So what if Sally said her answer was she's feeling unsafe to go back home today? And another question is, would DHS need to be involved in this case regarding kids' safety? And another one is, does the GP need to, either whether Sally feels safe or not, does the GP need to inform anyone about Sally before the practice lets her go back home? So there's a few questions there around the patient leaving the practice.
There is no mandatory reporting of women involved in family violence except in the Northern Territory. And in the Northern Territory there is a requirement for GPs to report. My personal feelings are that reporting isn't really helpful. It may in fact prevent the patient from being able to tell you what's going on because of what they worry about. We will talk about the children and about mandatory reporting of children in the next webinar. In this situation, there's no evidence that these children are in a situation in which you need to be reporting to docs at this point in time. So if Sally had said, no, I'm not safe to go home, then you start into a process of finding her a place she can go where she is going to be safe. And that may be to family, it may be to friends, or it may be to a refuge. And if we were going to do that tonight, then the way I would go about that is that I would ring the domestic violence line to find out about a refuge that has a bed for her and 2 children. So we have to, in terms of how do we feel about letting Sally go, then I think we have to work with Sally and we have to respect what she's saying, even if we have doubts about it. So how would you feel about letting Sally go home, Brad?
I'd feel terrible about it, Libby. And this is the challenge, I suppose. I thought it was just a boy thing, but as GPs, we like to problem solve. I mean, we like to come up with the solution that's going to help here. And, in this case, reporting this to the authorities may not actually be the solution, but rather be quite inflammatory and cause Sally considerable more problems. And as you brought out in the case scenario, you came up with some solutions, some plan Bs for Sally. So contacting her sister, making sure that she's got some options, not just that she's got them, but she's actually considered them and when she might invoke using those. And at the end of the day, in order to move forward on this, we need Sally's trust. We need to develop that relationship with Sally. And I think that, to be honest, if Sally didn't want our help or was worried about our confidentiality or that we might actually report her, I suspect that she's unlikely to tell us that she's unsafe at home. She'd probably cover that up and get the hell out of our practice, I suspect. Whereas the fact that she's being open and honest with us shows that we've got somewhere to go here. And whether that be a refuge, as you say, or a family, or maybe coming to terms with our own difficulties over letting her go, but making sure that she knows that she's got somewhere safe here in the practice to come back to. And as alluded before, making sure we've got that follow-up process in place so that she can come back and we can see how she and the kids are going.
And Sally, how do you feel about some of those questions?
Oh, I mean, I think you guys summed it up perfectly. If I'm talking to you, I'm talking to you. And if you involved the police without talking to me about it, I wouldn't come back to you. And even if you left and gave it anonymously, it still would be pretty obvious who it was. So what you said was perfect.
I'm hoping that we did answer quite a number of questions in that little chat then, because quite a few people have been expressing their concern about the patient's safety once they have disclosed the domestic violence, and so the fear that comes from whether it might even be as far as a death threat should anyone ever find out, etc. So I'm hoping that we answered quite a few questions there. We're coming quite close to the end, so Libby, did you want to move on to the next slide? And any questions that we haven't addressed, we will do so via email offline after the webinar tomorrow.
All right. So I'm just going to do a bit of a summary about some of the things that we've talked about tonight. And if you look up the white book on the college website, you'll find that we've got the 9 steps to intervention, and we call it the 9 R's. And those R's are about role, and the fact that you've come online tonight to think about and talk about these issues means that you see that you yourself as the GP, your practice or your AMS have a role in helping our patients who are experiencing abuse and violence, and that we have a readiness to be open to recognise the symptoms and of abuse and violence, and that we are willing to ask directly and sensitively about it. So some women will spontaneously tell us about this, but many of them will not quite have made the link between their symptoms and what's happening to them at home, and numbers of them will be still in that pre-contemplative phase where they haven't recognised that really what is happening to them is abusive. So we're helping to recognise this and to ask directly and sensitively about it. And then when they do respond, as Sally did in the second time we talked to her, then we're going to respond to their disclosures with emphatic listening, so that we're going to explore things about the risk. And in the white book there's a whole chapter on risk and safety issues, and that we're going to make sure that we're reviewing the patient as we discussed in the case for follow-up and support, and that may be a very long-term thing, as I was saying before, that some of these people who are involved in abusive situations, it takes them a long time to be able to decide how they're going to manage this, if they're going to leave, what's going to happen. And so, and then when it is appropriate, to be able to refer. Please don't just send these patients away. They've come and spoken to you, and they don't wish to be abandoned, but they will wish to be referred when that's appropriate, and that's working together with our patients around that. And we need to reflect. This is a really difficult issue for us and for the whole of our society. It's a huge problem in our Australian society at the moment, and we need to reflect on our own attitudes and management. We would like to believe that all families are supportive and kind to each other, but in fact that is in fact not what's happening in some families, and we need to be really careful that we don't also blame the victim. And we need to, through this process, have a high level of respect for our patients, for our colleagues, and for ourselves as a sort of overarching principle in this sensitive work. Please feel that you can ask for help. Please feel that you can get support in these situations. So we've nearly come to the end of the hour. It's gone very quickly, and these are just some of the resources that are available. There's a whole chapter on Aboriginal family violence in the White Book. There will be another webinar on dealing with children. There's an active learning module on GP learning about domestic violence, and certainly we're happy to take further questions and things if you would like to send them in. Now, Brad, what else would you like to say?
Libby, this has been a really great opportunity. The session this morning and again now has been really well attended, and you know, it's given us a great opportunity to discuss a really difficult subject. And the bottom line is here, there's no absolute right or wrong way to do this, and it really is just about using our general practice skills and enhancing the skills of our team to make sure that we respond to Sally's needs and to Sally's family's needs in order to make this safe for her and her children moving forward. So I would like to thank everyone for showing their interest in this and taking the opportunity to revisit our skills. To thank everyone for giving up their time. It's really important, and to you guys for all the work that's gone on behind the scenes to actually make this happen. I look forward to part 2 with the looking at the effects on children next week. Thanks, Libby, and to Summer. Thanks.
And Sally, what would you like to say? Is thank you very much for being Sally today or tonight, and have you got a final word to say? I think the patient should have the last word. So I think
sadly, Libby, we might have lost Summer in amongst that.
We've lost Sally. Okay, so we would like some feedback from you, and we will be sending you an evaluation form by email, and we would very much appreciate your filling that in. And thank you very much for participating in this, and let's keep working on making our part as general practitioners really work in this area of family violence. Thank you so much.
Thank you, Libby, Brad and Summer, and for everyone's attendance tonight. Your input's been fantastic. Thank you for joining us. The webinar has now concluded.